Hello and welcome to this webinar today. My name is Kerry James. I'm the Chief Executive of the World Hepatitis Alliance. And today's webinar is about COVID-19 and viral hepatitis. These are very uncertain times for a lot of people, and that includes people who are living with viral hepatitis. So we hope today to provide, there's things that we know, there's things that we don't know, and there's things that we really need to talk about. So we are really providing this webinar as a space to do that. And to get some opinions from some people, some experts in the field, and some people that are on the front line of the COVID response in different parts of the world. So with that said, I'm going to allow my panelists to introduce themselves and tell us a little bit about themselves and how they've been involved in the COVID response so far. So Sue, would you like to start?
Sure. My name is Sue Wong. I am the current president for the World Hepatitis Alliance. I am also living with hepatitis B, and I am a physician. I practice internal medicine in the US, in New Jersey. I run a medical practice called the Center for Asian Health, which does a lot of outreach to the Asian population, and I run a number of our viral hepatitis programs. So I work in the outpatient setting. We are obviously focusing a lot on telemedicine for the safety of our patients and for the safety of our staff. I am working with a hospital that's been hit pretty hard by COVID. We are exceeding our standard bed capacity. Our ICU in the hospital usually holds 20 patients, and we're now talking about 100 COVID patients at our ICU level. So the New Jersey, New York City area obviously has been hit very hard with a lot of focus on the acute care side, but there is a lot of concern, and we are, as frontline workers, the ones identifying patients, helping direct patients to know whether they should go to the emergency room, how to get testing. Testing is very challenging still, especially if you're not very symptomatic. And so all the issues that I feel like we've discussed in the world of hepatitis in terms of access to testing, care, and treatment, I feel like I really highlighted in everybody's face with COVID, because the lack of testing is such a big issue. And this is, so it's very interesting, having worked in another infectious disease, to see how it's the very similar, very same issues that are confronting us that also impact, COVID. So thank you.
Brilliant, thank you. And Bob, would you like to go next?
Yes, my name is Robert Gish. I live in San Diego, and I'm involved with liver disease patients from many different perspectives. And of course, there's an overlap with COVID-19. Number one is I work at a federal clinic in San Diego. I'll be seeing 80 patients next week in that clinic with a variety of different types of liver disease. And COVID-19 has changed the entire structure of how we run that federal clinic, which is an outpatient facility, but with screening, education, and a change to telehealth and telemedicine, which I think we'll talk about later, has been really dominant. Also, I work with Hepatitis B Foundation. We get about 12,000 telephone, email, other types of contacts or consults each year. And of course, in the last 3 months to 4 months, we've been dominated by COVID questions in those patients with chronic hepatitis B and other types of liver disease. I also advise a large number of healthcare groups, hospitals, and organizations in California and Nevada, and I'm working globally in countries like Vietnam and Armenia. So really, this is changing my practice, our lives, our patients' lives.
Absolutely, thank you. And Kosh?
Thanks, Carrie. My name is Kosh Agarwal. I'm a liver specialist, and I work at King's College Hospital in London. So I'm giving you a more European perspective. So I'm a liver specialist, and I'm also a transplant hepatologist. So I'm involved in the care of transplant patients. My interest is in hepatology, and particularly viral hepatitis. And we have had really radical changes in our day-to-day working, certainly in London, for multiple reasons. So currently, for example, our transplant program is essentially on hold. And we have been reconfigured to inpatient work for the last 6 weeks. Actually, we are starting to see a decrease in the number of COVID-affected patients. And it has been a fairly hard slog over the last 6 weeks or so. And I agree with all the comments. It's great to be part of this webinar, so thank you for the invite. There's a really radical change in how we're delivering health for our existing patients and actually dealing with managing patients, whether they are very sick in hospital or even in an outpatient setting. And there are very big synergies with regard to the world of viral hepatitis. And I think the last thing I'll say is, whether you're in Europe, in the Pan-Pacific Asian environments, or in North America, the information that's coming out is changing so rapidly. I think it's really important that these opinion-led webinars can try and reassure and give some clarity to the current situation that we have. So thank you for the invite.
Excellent. Well, thank you all again for agreeing to be part of this. So just a little bit about the format for today. So Bob's just going to give us a couple of slides just to kind of lay the groundwork of where we are with understanding COVID-19 and viral hepatitis, and we'll present a few more throughout. And then previous to this webinar, we've asked the community to send in questions. So we have a list of questions that would have been sent in by people that are responding on our social media channels. So we'll be asking and going through those and discussing those. And then at the end, if you have, or during the broadcast, if you have any questions or comments, please leave them in the comment section if you're watching on Facebook or YouTube, or reply on Twitter, and we'll do our best to answer those questions. We'll answer those questions afterwards. So let's get started. So Bob, do you want to kick things off?
Thank you, Kerry. I do appreciate being involved with this. The World Hepatitis Alliance, a powerful, global, influential organization, really out to help patients primarily, and providers and nonprofits and all these great parts of our integrated system. So let's just start off with a little bit of terminology, if that's okay. COVID-19 is the disease, and the virus is called SARS-CoV-2. This started in Wuhan, China. People keep quoting December, but there is some evidence it probably started in October or November. They look at special virologic studies. Right now, as of today, 2 minutes ago, it's over 2.6 million cases of COVID-19 or SARS-CoV-2 virologically have been reported worldwide. This SARS-CoV-2 is very similar to the SARS virus. I'm saying similar, about 80%, and remotely related to MERS. But these are animal-derived viruses that jump into humans, and usually we think of something they went through what's called an intermediary host or some other animal potentially. Now, this is pathologic. It's a problem to humans because it attaches to special receptors. These are places in the bloodstream or blood vessels that are called ACE receptors, ACE2 specifically, and it binds very tightly, gets into different cells, which is liver, intestine, pulmonary, lung cells, and causes this inflammatory response. Part of it's virus and part of it's the immune system, and can result in this incredible total body inflammation, and can lead to increased clotting, strokes, heart injury, of course, lung injury. And we're going to talk a lot about liver today and the overlap with hepatitis, viral hepatitis, and hepatitis C. One other terminology I think is very important is people often confuse liver enzymes with liver function. So you really have to be careful when we're talking and we're reviewing the literature. AST and ALT are liver enzymes. Bilirubin, a clotting test called INR, or albumin are liver function tests. And most of these studies talk about liver function abnormalities, but what they're really talking about is liver enzyme abnormalities. China's had the biggest experience. They've published a lot about clinical features. We'll get into that shortly. And a lot of our patients who have COVID-19 have comorbidities, which means simultaneous diseases, and liver comorbidities or simultaneous liver disease, such as hepatitis B and C, we'll be talking about more today. Back to the enzyme issue, AST and ALT are what we look at, and for some reason, this enzyme called AST is much higher than ALT in these COVID-19 patients. We have a little box here that's a slide talking about recent data and comorbidities and the prevalence of elevated liver tests and changes in patients with COVID-19. We can go into that a little bit later, but it's important to note that this is a consistent finding across all these different COVID-19 studies, that the liver is part of the injury pattern, whether it's a direct viral event or viral immune or immune dominated, we don't quite know yet. But I think that's a good summary, Carrie. Is that a great start?
No, that's great, Bob. Thank you very much. That really set the scene really well. So I guess now we'll go straight into the questions. So the first question that was sent in was, what are the basic strategies for staying healthy and protecting yourself if you have hepatitis in relation to COVID? So Sue, would you like to start that one?
Sure. I'm on a couple of the message boards for patients, and this has been a very common question. I think, what do we need to do to stay safe if we're living with hepatitis? And I think a lot of it is really the same messaging that we're getting for anybody, really. So I think social distancing is a word we're all getting to know in terms of how important it is to reduce our exposure to a lot of people during this time. I think what's very different is that this is a new disease, so we don't understand the transmission. We know some basics about who's more at risk, but really at this point, anybody's at risk. Originally, we thought it was mostly older people, that children were immune, but we're seeing a lot of children and a lot of completely healthy people actually get COVID. And at this point, it's impossible to predict who's going to get it more severe than others. So the general strategy for everybody is to reduce your exposure to people. And we know that, and if you are with people, obviously we know that it's not possible in a lot of settings, is to protect yourself. And there's been a lot of controversy over whether masks are useful or not, and who should be wearing the mask. We've seen this evolve just in the couple weeks or months actually in the US, and I'm sure this is happening across the globe too. And at where we are in the US now is that there is a general recommendation for even the public that's asymptomatic to be wearing masks if they're around other people. So, I think what this webinar we're trying to do is kind of provide some opinions, recommendations. There's going to be a lot of variability based on where you're located and what perhaps the burden and the incidence is of COVID. But I think with a good representation here, everybody who's listening to this can kind of take our advice and some of our opinions, into account, as you're balancing it out with what advice you're hearing from your region too. So that's just kind of a background statement for everything that we're saying today. But so for viral hepatitis patients, I think there's no data saying that we're any more susceptible at getting COVID than anybody else. So I don't think we need to be fearful in terms of being more at risk of acquiring the disease. I think if you're on immunosuppressants post-transplant, it might be a different story. But for the average viral hepatitis patient, we're probably at the same risk as anybody else with the same clinical scenario. So some of the comorbidities obviously come into play too, which we'll talk about. But what I tell a lot of my patients really is, stay home as much as you can. And a lot of it is staying healthy in other ways too. So I know for a lot of the viral hepatitis patients are really focused on like my hepatitis, but it's really about your whole body and staying healthy in other ways, eating well, staying active. Even if you're at home, there are a lot of exercise videos. People can at least walk around. Your mental health is really important. We talk about how just because we're physically distanced from people doesn't mean we're avoiding social contact. And if you can at least stay in contact with your support system using video or phone calls, that's actually really important, keeping a normal schedule. All these things go into play because we do see a lot of anxiety with COVID. And so a lot of what I feel like we're doing as primary care physicians is really trying to focus on, the good things and being grateful for what you have. And even if you are symptomatic, remembering that the most people who get COVID are actually very mild and will self-resolve. And kind of a lot of it is our perspective on this thing. So overall health, I think, is an important thing to focus on.
And Bob and Kosh, do you have anything you'd like to say for this question?
I think from my perspective, what Sue described is keeping calm, keeping rational, think through this as an individual with your family members, your support, and your providers. And yes, and just work with your providers for adequate monitoring.
Yeah, I would second that and second what Sue has said. I think the key thing is not to neglect your general ongoing health with conditions that you have, And then importantly, and I think this is an important point that Sue touched upon, being holistic around your care in what is a very strange environment for all of us, and making sure your physical and mental health and your structures to support those are there, and try to balance out the messages that you're hearing that can change. So it is actually changing our overall view to a more holistic kind of view, rather than focusing just on, oh, I have hepatitis or I have this disease. It's broader general health in the context of what is a societal change in how we're moving around on a day-to-day basis.
Absolutely, that's so important. Okay, so the next question that we have is, what do we know about how COVID and how it affects viral hepatitis patients? Are they more likely to get it? Will they have more severe symptoms or more likely to die from it? Bob, maybe you could start us out, and I think you've actually got a good slide on this as well.
Well, I think that Sue did a great job of putting some intro comments here. So viral hepatitis patients per se are not more at risk of getting SARS-CoV-2 viral infection, or once they have the infection, the disease manifestations. So that's very important, but just follow common sense, follow all these basic rules that we've been talking about today. Now, if you have moderate to severe liver disease, and then there's a liver impact of SARS-CoV-2 or COVID-19 as a disease state, you could theorize or hypothesize or make an opinion that the liver disease might get worse in those individual patients. We do see some high liver enzymes in our patients and occasionally liver dysfunction. So it's really about monitoring, and really patients need to know, what is the stage of their disease? How good or how bad is their liver health? How good, how bad is their liver function?
And Kosh, from a hospital view, what have you seen, or?
So I think we can reassure people in the context of viral hepatitis per se, whilst we have a new disease which has almost 70% of patients having some liver abnormalities, that there is no increased risk of severity or risk of getting COVID in the context of having viral hepatitis. This is, after all, a World Hepatitis Alliance webinar. I agree that conceptually, patients who have immunosuppression and patients who have end-stage liver disease or may be potentially at higher risk. But again, it's a common sense and calm approach. We'll touch upon it, but personally for me, what I'm seeing is patients with more cardiovascular and metabolic comorbidities are those patients that we see in the hospital who seem to have more aggressive disease from COVID-19, who end up coming into hospital and seem to have more problems. I think we have to counterbalance everything we see. I can tell you in the last week, I've had 2 liver transplant recipients who tested positive, who've been totally fine, and after we've monitored them, have gone home. So there is a spectrum. Everybody is different. We shouldn't just look at it through the liver disease paradigm, and it is a systemic viral illness. But for me personally, the hint that I get is other cardiovascular and diabetes and obesity as potentially drivers. And this is why in this current environment, we talk about models of care, looking after your other conditions and looking after your health generally is still a very important part for all members of society and everyone around.
So I wanted to ask you guys, as specialists, because I think one of the questions that comes up for primary care doctors is the elevation of liver enzymes that you're seeing. Does it seem to also potentially cause a reactivation or flare of people in hepatitis, or does it seem like it's separate and doesn't, at this point, from what we're seeing, doesn't necessarily interact with the hepatitis virus or the disease?
Oh, why don't you go first?
Okay, this is definitely opinion on opinion, because we really don't have any data that says that B or C, hepatitis B or C, are suppressed or flare or increase during COVID-19 disease. So I don't think there's going to be a major interaction from that perspective. We've seen, for instance, hepatitis B flare when we're treating hepatitis C, especially in patients who are core antibody positive. I do want to make a point which we've been hinting at, which is in a hepatitis patient, viral hepatitis patient, you need to look for other types of liver disease, and specifically fatty liver, and fully assess them for other parts, what we call the metabolic syndrome, which includes diabetes and high cholesterol, high fats in the bloodstream, and the total liver health. Don't just focus on B and C, B or C. Think about the whole patient and the whole liver health assessment.
Excellent.
I would agree with that. I have nothing else to add. I agree.
Great. Okay. So the next questions we have are really about care and about treatment. So maybe, Bob, you could set the scene for us on this kind of area discussion, please.
Oh, thanks very much, Kerry. I've got a very strong opinion about this, and I've been interacting with some of the international organizations when they've come out with what I felt were relatively weak statements about managing B and C in this setting. So if I'm seeing a B or C patient in my federal clinic or one of my outreach or one of my telemedicine sites, and we're sitting in this COVID pandemic, I am telling them you need to be on your hepatitis B medication. You need to stay on your hepatitis B medication because it makes management of COVID-19, if that evolves, simpler. If you treat hepatitis B, suppress B, liver enzymes come down, and in some rarer patients, liver function can improve. Same thing with hepatitis C. Hepatitis C causes liver tests to be high. If they come in with COVID-19, is it the COVID-19? Is it the viral hepatitis C? We don't know. So I put all my C patients on treatment immediately so I can optimize their COVID-19 disease management if that were to occur. And of course, this is all about capacity, but most clinics are now in an outpatient setting and they have telemedicine and pharmacies are functioning. I've had no trouble getting hepatitis B or C medications to my patients. So I feel strongly they've got it. They get treated now. It makes their management simpler in the future.
Right, so that's pretty clear. So if you're diagnosed with hepatitis B or C now during the COVID situation, then your opinion is people should definitely start treatment. They shouldn't wait until after this is finished.
I feel strongly about that.
Yeah.
So yeah, we've had this come up as well. We have a automated hepatitis B and C screening program at our hospital. So if anybody comes in and has not been tested for hepatitis B or C, and for Hep B, if they're coming from countries that are high prevalence, it automatically fires. So we continue to do the screening in the midst of COVID. So obviously we've had positive patients, and a number of the positive patients are actually severely ill with COVID in the hospital. So it's not their primary, it's not a primary importance. And what we've instructed our navigators is it is okay, obviously, not to start the treatment while they're, with battling COVID, but that would be a follow-up once they're discharged. So like you're saying, Bob, you kind of have to weigh out what's happening with the patient. For those who are fine and stable, we do address, starting getting evaluated for COVID, for their hepatitis B or C. Obviously, some of the limitations are getting that initial assessment of blood work because there's some concern of not doing, excessive blood work. And so we've kind of had to temper that with also the patient's willingness to get blood work, the availability of phlebotomy. But we have certain sites that do phlebotomy, and patients have been able to get tested. So with our telemedicine also and our pharmacists, we've, one of the good things that's happened in the US, at least, is they've lifted pre-authorization requirements for medications. So actually, potentially, it could be easier to get some of these meds that previously have been very difficult because of all the pre-authorization requirements. So it is possible and recommended, as long as, people have the resources and everything's in place.
So I'd just like to add, I would take a middle ground there from both Bob and Sue. I think anyone with an existing condition, let's say hepatitis, should be exploring their healthcare options to get optimal care. It's as simple as that. Whilst the world has been dominated about the coronavirus pandemic, we're now seeing patients coming into hospital who have neglected semi-acute and acute and their chronic conditions, and actually there'll be a significant burden of morbidity or complications for patients associated with that. So I agree that people should not neglect their ongoing medical conditions, and I, as a clinician who's involved in viral hepatitis, we see patients in hospital, we're screening those for hepatitis B and C if they have abnormal LFTs, and we're going to pick them up and make a decision about what their clinical status is, about whether they need treatment or don't need treatment. But we have started in patients with COVID who are getting better on their hepatitis C medication when they've come up and been positive for hepatitis C. And likewise, those patients with hepatitis B, if it fits within the model of care for them, we certainly would like to optimize their care and not neglect any other conditions that they have. So I wouldn't defer healthcare only to focus on the coronavirus clinical situation that we're in. It's changing, and I appreciate the messages that have been coming out to all members of the public. And my wife is a doctor, and she's confused about what the messages are. But I think if you have underlying conditions, people should be accessing healthcare as best they can and tailoring it with regard to the resource environment that they're in.
Can I make one more comment, if that's okay? I started working with the Hepatitis B Foundation just before this SARS epidemic started on an initiative called Know Your ABCs. And that is part of this global elimination program for viral hepatitis, we think, from the Hepatitis B Foundation. And Sue is the president of WHA. We're going to hopefully get you and your whole team more involved with this. We've gotten NVHR and other people to buy in. So there's a sort of spreading nicely. And that is, every adult should know their hepatitis A, B, and C status. And just think about this. Everybody's going to be coming in for COVID or SARS-CoV-2 testing. It's either going to be PCR or serology in the very near future. And while they're coming in for that COVID testing, they should get their hepatitis A, B, and C panels done. So we can really get to what's the prevalence of this disease in adults and link those people to care. So it's nice that the COVID or coronavirus starts with C. So when you know your ABCs, and C is plural, viral A, viral B, viral C, and your coronavirus status, and that's in everybody's chart.
I think, yeah, absolutely, that's brilliant. It's all about making every contact with healthcare count, right? And try to get as much out of each one as possible.
I couldn't agree more. And just to give you a sort of London and European perspective, the UK is still in Europe, and that's a good thing, is that we have our outreach service for homeless patients looking for blood-borne viruses, hepatitis C, hepatitis B, HIV. We also check for TB, and we're now reconfiguring that service to screen patients for coronavirus because they're in places of safety. And of course, we will be looking to continue that as well as checking their coronavirus status. So it's making every input count. And I agree with the sentiment that Bob has put forward.
Yeah, I think that's great. I think the whole COVID pandemic has kind of made people a lot more aware of how important testing is and what the options are. And there's a lot of discussion about all, the rapid development of tests and point of care tests versus lab tests and how long it takes. And I think it's a good reminder to let people know that, we've had excellent Hep B and Hep C tests for a while, and some of them are point of care. They're cheap. They're actually much have higher sensitivity and specificity than some of the COVID tests out there. And it's something, to ask for from your physician. So I think it's a great initiative, Bob, and I've been very supportive of it. I wanted to ask if there was any, particular things you wanted to put out there in terms of the recommendations from EASL and AASLD. I think it's good for people to realize that there are some of these evolving recommendations from these two societies, and the websites are quite good, for people to look at, and they do continue to update them.
So I think we kind of covered this already, but it was a specific question, so I'll ask it specifically. And it was about if someone has already started hepatitis C treatment, whether they should continue it during while there's a risk of COVID, or whether they should stop and then start again later.
So I'll state that just like with hepatitis B, patients that are on treatment for hepatitis C should continue their hepatitis C treatment until the end and not interrupt, specifically because of concerns about COVID-19. If they come into a hospital setting with COVID-19 symptoms and signs and are virus positive, continuing the hepatitis C medication in that setting would be customized to the individual patient in that case in collaboration with the patient's provider. So hepatitis C is a little bit more complicated than hepatitis B in that setting. There also is the issue of drug-drug interactions. So the patients and providers need to be making sure that this is safe to continue a given medication as new medications are being added to add COVID-19 or its complications.
And that does kind of take us to the next question, which is kind of related. And it was about, what do you recommend for hepatitis patients relating to their care, especially some hepatitis B patients who might have problems accessing their treatment if they weren't able to get, a few months in advance. Not everyone was able to get their prescriptions in advance. And what could be the impact of a gap in treatment for hepatitis B if it's unavoidable? So maybe Sue, would you like to start that one?
Sure. Yeah, this is definitely a question that has come up with our patients. So we have encouraged everybody to, get enough of their medicines. And some people have gone to the pharmacy. We've encouraged everybody as much as they can to switch their pharmacies to mail order if it's available to them where they are, because a lot of pharmacies are, there are already mail order pharmacies that existed before this, and then some local pharmacies are now delivering to people so that they don't have to make, a trip outside the house. So obviously this is not available everywhere around the world. So there are going to be people who say, well, I have to actually go to the hospital, which is in the main city, and in order to pick up my medications, and they've blocked any travel, or I don't want to go to the main hospital where COVID is, maybe has really hit them hard. And so that is completely understandable. I think, in this reality, we obviously, as physicians, are always counseling patients on compliance and take your medicine every day. And it could be really bad if you don't because of resistance to this and that. And so I think some of it is we do want to reduce the anxiety around that, because in real life scenarios, sometimes it just does not happen according to the way we would like to see it happen. And for the most part, the vast majority of people who are not on their medicines will not have a sudden flare right away, or a flare at all. We counsel on that because it happens in a small percentage of people. But in reality, I think for the most part, people are not taking their meds. And for Hep B, I hate to say this stuff because it's like not what our recommendation is, but in real life, we've had patients who have, if they only have 30 days left, will actually space out their medications. So for example, tenofovir is a high enough dose and potent enough where patients have had to space it out every other day. The impact is still actually pretty good. The viral load is still suppressed. So these are not, normal recommendations in a normal setting. But we've had patients do that also if they just can't afford the medication, and they've had a decent effect even from that. So I'd love to hear what Dr. Gish and Dr. Agarwal think of that.
Well, my main comment is that there's a strange pattern of giving patients just 30 days of whatever medicine they're taking. And then there's some theory about, that'll make them come back and be more compliant. But really a 90-day supply is much more logical from an operational and cost perspective. But I think part of it's an insurance company. They want to save money by not giving people 90 days because they might switch to a different plan, or somebody might decide to stop their medicine. So I prefer 90 days at all times, not just in the COVID times. So that's my additional comment, Sue, but I agree with everything else you were saying, and be cautious. One more thing is from Hepatitis B Foundation. We get all these comments from patients all the time who have hepatitis B medications that were prescribed, but they stop them on their own. They don't talk to their provider, they disappear, they don't come in for follow-up. They just want to come off their medicine. They're not concerned necessarily about a flare. They just don't want to take the medicine indefinitely. We have to educate them that flares are rare, but people should be monitored. And if they're going to stop their medicine, tell their provider.
Yeah, I'd like to add a couple of comments. So I think always the aspiration should be to maintain the care pathways that people have, and we're talking about viral hepatitis. So I'm clearly very keen to emphasize that patients should remain engaged in their models of care, and certainly not take a view that they're troubling their care providers or the systems, because their conditions remain important as well. Having said that, in exceptional circumstances, I would agree with what Sue has alluded to, but clearly systems need to be better, as Bob has stated, in the delivery of medication and the remote delivery of medication. So to give you what happens in London and in England, we give 6 months of suppressive hepatitis B medication in one go. But we have to prescribe it from the hospital because this is not reimbursed in the way that our NHS is built. What's happened in the context of the coronavirus problems is that now we've been able to become much more functional in getting the drug to the patients rather than the patients having to come to hospital. If they need to come to hospital for a specific clinical reason, then clearly we're still seeing them, but actually we're able to get immunosuppression out to transplant patients. We're able to get Hep B therapy out to hepatitis B patients. We're getting hepatitis C therapy out to patients. So actually the systems will change to become more patient focused and more patient friendly. And certainly there are great lessons from the world of hepatitis C with regard to eradication and these new therapies that should translate to a much more patient-focused way of delivery of care across the world, depending on the resources, particularly with the delivery of medication.
Absolutely.
Kosh, I'm curious, how do your hospitals do it? Are they actually delivering it to the patients' homes?
Yeah, yes, they can do it, having, let's be very clear, we still aren't able to do electronic prescriptions. But for example, which is a thing that I bear a cross for the last 10 years trying to do, which don't get me started on that. So we are unfortunately handwriting prescriptions, but they can flex to get those delivered from our own pharmacy at an industrial scale out to patients or to their local pharmacy so they can collect it. So in the US, home delivery, home dispensing or pickup from local pharmacies much more established. We have, moved 5 years in the last 3 months. And actually this is going to be beneficial for all patients. And certainly there are patients who are stable on therapy who may not need to come up. We may touch upon telehealth and other models of care. Personally, just to make it more interesting in the discussion, I still think there is huge value in having an intermittent physical visit and a face-to-face consultation, not only because of the diagnostics, but also because, for example, the field of hepatitis B is changing so radically. So, but telehealth really will grit in, certainly in the UK setting, and we've been a little bit slow in embracing these models. And after this is finished, we will be delivering care in a much more patient-focused manner, which I think is a good thing.
Great summary.
Definitely agree. Yeah.
Brilliant. So there's a lot of talk going on in the media and other places about existing treatments and existing medications that might be able to be used some way to combat COVID-19. And there's even some talk about hepatitis treatment being used to combat COVID-19. So, I mean, what are your views on how do we weed through this information and what, do you know what I mean? How do we interpret what's being said? So maybe Bob, if you'd like to start.
Well, thank you very much, Carrie. This has been a major focus of mine over the last 6 or 8 weeks because I've given a series of talks on the treatment options that are available out there. And I think the word caution in capital letters has to be the first point that we need to cover with our patients and other providers and support individuals, because there's been a lot of what I'll call advertisement going on for miracle medications that are being repurposed, meaning they went for one disease, now we're taking them to another disease. That we have to wait for proper clinical trials, not just for efficacy, not just for the effect or possibility of control or cure, but for side effects. Because some of these medicines have been used for lupus, like hydroxychloroquine, been around for many years. It's very important that patients who are taking them for lupus or rheumatic diseases can still have access. But we also know what their toxicity is, and only in prospective controlled trials, which means we move people in order over time, and we have a non-treatment group or a placebo group to see, is there really a benefit and what's the safety? So hydroxychloroquine, And a VA study, it's a veteran study that just came out within the last week, showed a much higher mortality rate, about 2.6 times in those individuals who are on hydroxychloroquine for SARS-CoV-2. That's a huge red alert to me that we really have to balance benefit and risk in these patients. Many other medicines are being used, are being looked at. There's, I think, close to 600 clinical trials that are registered. I'm going to estimate over 80 different medicines are being looked at in different settings. One of the hottest topics is the drug from Gilead called remdesivir. This inhibits one of the proteins the virus uses called a polymerase, which helps lengthen that viral genome. And what we found out today, at least from a web release that was there, is that they're expanding the trial to see if they can discern where the treatment might be effective. So one interpretation is it's not working. I wouldn't go that far. I would say let's wait till the formal data comes out and also data from an expanded trial and find out where this works, because we got a hint that it might be effective from a case series that was in New England Journal of Medicine just a few weeks ago, but that's not the same as a randomized controlled trial, which is what we need. A lot of other medicines that are anti-inflammatory, they're being used. There was a rumor that ibuprofen was dangerous. That was not substantiated. So for pain and fever, of course, we're using acetaminophen or paracetamol. We're in the European area, up to 2 grams per day for fever and pain. And you can use ibuprofen or non-steroidals for pain and fever as well. Many other things are happening, but let's be cautious. Let's let the accelerated approach to getting these drugs out take their place, but wait for the real data.
Yeah, if I can come in, I think that's a really good summary. I definitely agree with the view that we need to be cautious. A lot of the data that we're seeing in the publications, and everyone is thirsting and hungering to try and get a treatment for what is a devastating disease in patients when they're in hospital with a mortality that is small if you take the whole group, but on an individual level, as clinicians, we think about the patients in front of us. We are seeing significant difficult times for patients and patients dying related to this disease. A lot of the studies are descriptive. They are describing, for example, patients who are on angiotensin inhibitors or ibuprofen or other drugs, and they're not balanced in the way that Bob is talking about, which is really in a structured trial, comparing it to standard of care and recruiting in a trial manner that will allow us to interpret the results. The other thing is the field is moving so quickly, and we've been dominated in our healthcare environments by really reacting and providing care for patients. At one stage in King's, we had 150 patients on ventilators. We had dermatologists looking after ventilated patients, which is an interesting kind of place to get to, but everyone, has done their best. So the trials are very built around the dynamic to provide clinical care. And sometimes the news has got ahead of the data. So I very much agree with Bob that we need to be calm. We need to not listen to any hype about hydroxychloroquine or other drugs. I think it's clear that remdesivir may have an effect, but we have to see what a larger study gives us. And the other group of agents is the immunomodulatory or anti-inflammatory agents. And it's really about the timing of using antivirals or other drugs to switch off an overactive immune system in response to a virus. The question will be is how do we do these studies when there's already a massive rollout very quickly with the associated hype, the need to have some good news coming out. Again, vaccines are moving very quickly, but I can't really see, for example, a vaccine coming into clinical practice before the end of the calendar year. It would just be something that has never been done before. So we just need to be cautious. We need to understand what the broader data is and be calm over the situation.
Great, Josh.
Yeah, I think these are really great points you guys all make. I think this is fascinating. This is obviously a horrible thing, the pandemic, but just watching science and public health just kind of happen at light speed has been really fascinating to watch. And I think I've seen the analogy of like, this is the express train versus the local train. And the local train is usually the way we go to get any, to have really good data and approvals, but we're kind of on the express train. And I think one thing for people and, at home is just to not get too caught up in this and not to look for the right answer, because there's not a right answer at this point. I think there's a lot of anxiety and stress over that. And so this is kind of a good perspective to take a step back and just, I think it's so important. It's clear that we need to buy time, right? We don't know the answers. And so buying time, staying home, keeping yourself safe is the message, I think, from all of this. I do have a question for you guys also, as somebody brought up the immunomodulators and the IL-6. Some of the medicines out there, are any of those contraindicated in people with viral hepatitis? Do we know?
So that's a really good question. So we're involved in all of the studies. We've been recruiting aggressively into the remdesivir study. We're starting to do some of the other studies. Again, an important point is a repackaging of drugs that are already licensed or that are near to license. Clearly, with IL-6 drugs, there is a hypothetical risk of reactivation of hepatitis B and also TB, and normal practice would be to check for these when they're used in rheumatology or in other fields where these are licensed drugs. And again, a point that really tells us how fast the field is moving is that in national studies in the UK that are involving the IL-6 immunomodulatory drugs that switch off an overactive immune system but may reactivate, these trials have gone so quickly they haven't thought about the potential risk for patients of other diseases. So internally in our institution, we've said, hold on a minute, guys. We know that there is a conceptual risk, and we're going to be safe for our patients, and we're going to screen for those conditions before we put these drugs into patients, even in a trial setting. So it is amazing that the speed is so fast, and that these trials are looking to recruit such fast numbers of patients that sometimes that these very important but simple pre-treatment requirements, particularly for the immunomodulators, are being sort of not quite part of the full discussion. So it is important when patients come into hospital that, again, their previous medical history is available for the teams that are involved in their care.
I wanted to build on Sue's metaphor just a moment, which the express train is. We want to make sure our patients don't jump in front of the express train or try to get on or off the express train when it's moving.
And that we get to the station.
Yeah.
And
yes,
another,
we want them to get to the station.
Can I add one more thing to what Kosh was describing, which is that whole issue about testing. And there's this fake news out about hepatitis B core antibody, that it has a high false positive rate. And if people have core antibody alone, they need to be boosted with vaccine. It's really the wrong message. Core antibody means exposure. And core antibody means people always will have some residual hepatitis B in their liver. And it's a marker that they need to be educated about reactivation. And Sue brought up, and Kosh just reviewed, the fact that we're using these immune modulators in this setting, including steroids. So B monitoring is important. And if liver enzymes go up, it could be COVID, but it could be B reactivation.
And I think just the last comment, I think the one thing that we will take away, hopefully when we get out the other side of this, is that we will understand antibody and antigen testing much better in the public, and we will understand what they mean about a protective response or not a protective response. And that, again, is going to be a good thing, I think, for patients.
Yep, everybody's getting a 101 on infectious diseases and the immune system.
Exactly.
Yeah.
And just like you all, we're talking about things changing so quickly clinically and in public health. And I know our members are telling us around the world, community organizations are having to change their practice and find new ways to deliver, the hepatitis services they always do, but also to, retool and help with the COVID response in those communities that they're taking care of, because we know a lot of the communities that are disproportionately affected by viral hepatitis are also the ones which are being disproportionately affected by COVID. So it's so important. So, talking about kind of innovation and new models and things, I was just wondering if, Sue, if you had any thoughts about, how community organizations can make themselves effective in this environment, and kind of evolve going forward?
Yeah, I think so. There are a couple things. I think you just touched on like health disparities and how, a lot of the communities who are already don't have good access to healthcare. I think COVID is actually a magnifier of these things. I think we're seeing that if you already don't have access, it's going to be harder for you to get testing in certain scenarios. So I think it is important. Some of the big lessons I feel like I'm learning from COVID, I realize are lessons that we've already had to address in the hepatitis world. And I actually feel like those of us who have been fighting the good fight in the hepatitis elimination and speaking up for our communities, a lot of these lessons can be shared with COVID in terms of we have been fighting for access to testing and how important the patient community is. I think demanding testing is something that you're seeing all around the communities. People asking their government, saying, why weren't we doing more? Why don't we have PPE, right? So this is where sharing stories, people talking about how difficult it is to get testing, highlights the importance of storytelling, right? So we've always talked about how patients need to share their stories because data is one thing, but hearing the story of somebody struggling, and in the US, we've had these stories of people sitting in cars overnight to try to get drive-through testing, coughing in their cars, sick, like acutely sick in their cars while they're waiting to get testing. And that just highlights the gaps that are out there. So I think a lot of the lessons we've learned in terms of advocacy, speaking up for your communities, demanding things is actually really important in COVID as well. Accessing, getting care. And then once we do have treatments, getting access to treatments too. So I think we're also looking to learn from our members and seeing what they're doing. I think we cannot possibly understand all the communities and resources and things that people are struggling with. And I think that some of the ideas, even like for me hearing from Kosh, like what the UK is doing in terms of the hospitals delivering medicine, those are good ideas that I can say, oh, maybe we should think about that. So I think this is an opportunity for us to really share stories, and for, even though our communities are mostly have been knit together by our work in hepatitis, this is an opportunity for us to use our network and to talk about how we're also getting care for people for COVID. So I look forward to hearing from our members on ideas of what they've done to kind of share stories with other people.
Absolutely. And if we're really talking about large-scale scale-up of screening and of, vaccination and all of these things, community organizations are going to be the fast track of getting that out to the most in need communities fastest. So I think that's it's going to be a really important thing to keep an eye on. And Kosh, did you want to talk about, you talked a little bit about patient-centered care and, evolving models of care within the hospitals. How do you think this COVID is going to change how we address hepatitis and health maybe generally?
I think it's really important that we recognize that the inequalities in society and disadvantaged populations are really disproportionately affected by COVID. We have an amazing ethnic diversity in my part of London, and we're really seeing certain populations affected more. I would hope that healthcare systems will be more focused to those populations who may not come forward to healthcare, traditional models of care, and that we need to think about how we bespoke and make the access to care and also the community advocacy much more vibrant, so that we avoid this disproportionate kind of burden of illness that we're seeing right now. I think we're seeing really big changes in healthcare. First of all, we're seeing a reinvigoration across the whole spectrum in patient and provider care relationships. Everyone feels that they are doing the best they can, but really, to talk to what you're asking me, there's no doubt that telemedicine has taken off and has really become the norm. I think it has a place, but I do not think it totally replaces a face-to-face consultation. And also for us, it's difficult for us to get diagnostics easily. So for example, with my hepatitis B patients, we're clearly making sure they get their medication for 6 months, Bob, and we're monitoring them, but we don't have the diagnostics, and we're not able to do the ultrasound scan surveillance that we would wish to do. So the utility for the longer term really doesn't apply. And also, I think our information and our responsiveness to patient needs, I think certainly in a UK-based healthcare system, it's very overdue to have a much more patient-focused level of care and a culturally appropriate approach to different sorts of patients. So I think the models of care will change rapidly. And to give an example, which is really a research example, we are very interested in hepatitis B trials. We are obviously working with the hospital looking at trials for COVID. It takes us normally 5 weeks to think about a contract to set a study up. We're setting up studies in 2 to 3 days now. So the pace and the speed and the ability for health services to flex, they cannot rely on very ossified kind of ways of working. It will really change the way we deliver care, I think, for the better once we come through this.
Yeah, incredible. And Bob, your thoughts?
I agree with the role of organizations that support patients, the advocacy concept. I'm a major supporter of WHA. I was at the original meeting in Scotland. I'm honored to be there. The Hepatitis B Foundation, NVHR, there's a lot of other national, international, global advocacy organizations that are essential to catalyze what is happening, to support the patients, spread real news, make sure education is appropriate. So I'm very happy to be part of this. I think WHA's efforts are fantastic.
Great, thank you, Bob. And maybe Sue, just for a final comment, please.
Your questions about what innovations are happening from COVID, we think might continue, and how some of these may actually help us with hepatitis elimination is a really good thing to think about. I agree with Kosh that telemedicine is here to stay. I think it is very patient focused. I think the end result, ideal result is a combination of two. I also miss seeing my patients and obviously doing a really good physical exam in person. But I've been able to see that actually we are making it a lot easier for them to see us. I think it's making me realize as a physician that medicine has really been very much focused on the healthcare system, and you come to us, we deliver care on our turf. And, I think the days of when we used to go see the patients in their homes is doesn't happen anymore. And I think we've lost some of that, what it feels like to be in the patient space. So from my own experience, having done this with many patients, there's a certain level of, I'm learning a lot more about my patients because I can see what their environment is like, and I'm learning how they interact in their homes. And so I do believe that we are actually delivering care, making it more easy for them to see us, because a lot of times when they are the most sick, it's when it's hardest to actually get out of the house. They might be in pain, they might be struggling mentally also with actually leaving their house and having to deal with the healthcare system. They may not want to deal with our, the receptionist and the MA. And so the telemedicine offers a much easier option to access healthcare. And then I would say that what a lot of the communities in hepatitis have already been doing in terms of reaching the community where they are at is also where we need to move for, which is what's happening with COVID in terms of making testing accessible, in very novel ways. I mean, I think the drive-through testing is really incredibly novel, right? And you've seen this kind of with Hep C testing, where there's been more and more models of people doing these point of care tests in the community. You don't need to go to the hospital to get a Hep C testing. And so we kind of had already ventured toward that in a lot of our Hep C and a lot of the work that we've been doing in viral hepatitis, like really doing it in a place that is accessible to patients, delivering care right away, like get tested for Hep C, start your treatment the same day. Hep B, we've been a little bit more behind, I think, with what I'm seeing with like how rapidly FDA has approved a lot of these Hep B tests, the COVID tests. We would love to see the same with Hep B. We don't have yet a point of care test that is approved by FDA in the US, although it's being used in other parts of the country, the world. So I think patients and communities need to continue to advocate that, hey, we were able to do this for COVID. There's no reason we can't do more of this with hepatitis. And I think that a lot of the lessons in terms of providing patient-based care or community-based care, as we're doing in COVID, is really going to be important for us to see elimination all the way through for hepatitis as well. So I also think it's really important, it's highlighted some of the consequences when you don't have coordinated care, right? In the US, it's been very difficult because all of our health systems kind of don't operate together. And so our workforce has been very disjointed, and I think we're seeing the benefits of having truly coordinated care. And there are a lot of lessons from that as well. So those are my main takeaways. and just want to thank everybody for participating in this. It's a great conversation. I think we need to continue this as things evolve. We look forward to hearing more from our members as well.
Brilliant. Well, thank you all very much. It looks like we're just about out of time, and that might be a nice place to kind of wrap things up. This webinar and Bob's slides and everything will be on our online knowledge hub at worldhepatitis.org/COVID-19. And we've really created that so people can easily find the information that's available globally on COVID-19 and viral hepatitis, and not just specifically about the disease, but also about the communities that we're concerned with. So please go and check it out. Please go have a look, and so you can see Bob's slides in more detail. And I'd just like to thank our panelists for a fantastic discussion. And thank you all for watching. And we hope to see you at our next webinar. Thank you very much.
Thank you.
Thanks.